Today we're going to discuss Protocol 1. There are two major protocols in Cox technique, Protocol 1 and Protocol 2. The patient that is placed into Protocol 1 has a radicular component to their presentation. The patient who is placed into Protocol 2 has no radicular component. So in general terms, the worst of the worst patients are going to be placed into Protocol 1. So regardless of the etiology, whether the radicular component is coming from a disc lesion or a facet hypertrophy, possibly even the stenotic neuroforaminal canal, regardless of the etiology, if they have a radicular component, you're going to put them into Protocol 1. There's a basic formula for Protocol 1. Protocol 1 is the application of 3 20-second decompression sessions. 3 20-second decompression sessions. Each session consists of 5 4-second pumps, 2 down and 2 up. And we're going to elaborate on that in just a moment. Patient positioning, we've already described. Tolerance testing, you will have already done that and determined whether or not they could handle the cuffs or not, and the amount of pressure that would be applied by your contact hand. And then you will disengage the lever. Okay. Important points to remember is we always contact the spinous process of the vertebrae directly superior to the involved disc. So if it's an L5 disc lesion, an L5 disc herniation, we contact the L5 spinous process. If it's an L3 disc lesion or herniation, we contact the L3 spinous process. The contact arm, as we've mentioned, always remains straight up the long axis of the spine. We don't want to distract at an angle, or else we're going to get uneven distribution of our traction into that disc, and that might aggravate the case. We use an equal amount of force between the contact hand and the tiller bar hand. We learn, it's very important that you get the concept of the barrier of elastic resistance. Again, that point where the soft tissue is taut. And then no other movements except pure flexion distraction are performed until the patient is 50% improved both subjectively and objectively. In terms of the depth of your distraction, this is something you'll become better with as you progress with the procedure. But basically, once you've reached the barrier of elastic resistance, the table should not descend any more than about 2 inches. And one way to gauge that is you will see the patient's occiput will rock backwards in a nice fluid movement as you're doing your distraction. And then the line of drive is 2/3 I to S and 1/3 P to A. Okay, so let's say we're dealing with an L5 disc lesion with a right lower extremity radicular component, and that is the level of involvement. So if it's an L5 disc, we want to contact the L5 spinous process. So square yourself to the table. Again, split the knee with your thighs. Thenar eminence is going to slide down the sacrum and onto the 5th lumbar spinous process. Fully extend your arm, lock all the joints in, get the center of gravity directly over the patient's body so that your arm is going straight up the y-axis of the spine. Initiate your scissors movement. So whatever amount of pressure you put into the contact hand, put that same amount of pressure into the tiller bar hand, and then if we've tolerance tested her, then we're going to know what our treatment start point is. And so we'll just say in her particular case it was no restraints and medium pressure. So we're gonna find that barrier of elastic resistance, and then we're going to go slightly beyond it. We're going to use medium pressure, and then we're going to begin our first 20-second decompression session. Again, each session consists of 5 4-second pumps, 2 down, 2 up, 2 down, 2 up. And always ask the patient how they're doing. Say, Shannon, how we doing? Is that increasing your back or your leg pain? And hopefully that's a no. I believe that was 5. It might have been 4, but it needs to be 5, and then you can release. The concept here, very important. Concept here, this would be the patient's lumbar spine, okay? This would be the barrier of elastic resistance, and this would be your distraction. Very important that you don't lose the barrier of elastic resistance. We don't want to do this with the patient's spine, bring it into flexion and extension. So again, there's the patient's spine, that's the barrier of elastic resistance, that's where your distraction takes place. So again, to demonstrate, if it's an L5 disc lesion, we're on the L5 spinous process. Square yourself to the table, split patient's knee with your thighs, get a nice low profile, knees bent, so that you can bend your body forward without tipping over or losing your balance. Slide off the sacrum, lock in the L5, lock your arm, make sure it's going up the y-axis of the spine, equal scissors movement. All right, so we've just found the barrier. All right, now we're ready for another 20-second decompression session. 2 down, 2 up. Don't lose the barrier. 2 down, 2 up. How we doing, patient? All's good? That's 3. That's 4. That's 5. Okay, and release. Okay. All right, now between sessions, you want the patient to have anywhere from a minute or 2 or more, if necessary, depending on if they were really challenged to get through that procedure due to pain and muscle spasm. But between the 20-second decompressions, you're going to do some trigger point therapy. And all you're going to do is start with the erector spinae, the quadratus lumborum, and just look for trigger points. And if you find one, if you find a knot that needs to be worked out, then work it out with whatever soft tissue techniques that you've been instructed in. Go into the glutes, go into the piriformis and the gemellus muscles. If you find trigger points, just work them out. Just stay on the involved side. You can check the hamstrings or the popliteus. Again, if you find anything, work it out in the gastrix or the soleus. You're basically trying to do something as an adjunct to assist in getting the patient some relief, assist in the healing process, and give that area a little time to settle from the distraction. So any 1, 2, 3 minutes, and then you proceed onward with your second decompression session. Again, release the table carefully, square yourself to the table, split the knee with your thighs. Thenar eminence slides off the sacrum onto the 5th lumbar. Lock your arm in, get your center of gravity over the patient. Equal scissors movement, find the barrier of elastic resistance, and now you're ready to start your next 20-second decompression session. 2 down, 2 up. Don't lose your barrier. 2 down, 2 up, 2 down. Always inquire for provocation. Always read body language. Very good. Okay, so we've now performed 3 20-second decompression sessions. What we would want to do, if available in your office, is to apply some type of therapy to help reduce pain, spasm, and inflammation. You can use high volt galvanic or interferential. And basically, what I do in my office is I crisscross the disc. I use interferential. I'll use a 4-pad crisscross over the disc. And then on another channel, I'll find out where the most exquisite amount of pain is in the lower extremity, and then we'll crisscross that, and we'll keep that on with an ice pack over both areas for 20 minutes, giving the patient time to rest. And that would basically end the session for the day. And that is a basic synopsis of Protocol 1.